A painful truth is before us today. Progress on maternal, newborn, and child mortality has stalled. High rates of malnutrition continue to impact mothers and their children. Yet, our commitment to achieving nutrition and health for women, children, and adolescents has not wavered. We know that solutions exist and which ones work best: building resilient health systems and elevating community health workers, the heroes of this story.
آخر نقطة من دمي أنا بدافع عن مستشفى الأطفال قسم التحصين يا أمانة يعني.
We know health systems must be prepared for the next pandemic, better equipped and more responsive to the needs of children, adolescents, and women where they live. We know community health workers, 75% of whom are women, are the trusted knowledge in their communities, providers of integrated primary health care, and the best advocates for local priorities. In many places, they are the only providers for vulnerable populations, especially in humanitarian settings.
تحاسب الأطفال تقول مثلا بسبب الظروف الحاصلة إني ما أمشي الشغل ما في طريقة. الحالة الإنسانية صراحة تستدعى.
And yet, most community health programs are underfunded, while frontline workers are underpaid, under-equipped, and under-supported. This needs to change.
My goal in this profession is to see that one day we have an environment zero from infection. Seeing the children around, especially the healthy ones, it gives me joy. So I'm inspired, I feel motivated to do more.
Investment in community health workers and health systems can help end preventable child deaths and eliminate malnutrition. We have an opportunity for impact if we act now. Partner with us to deliver community health for all.
Your Excellencies, dear friends and colleagues, welcome to this launch of the Community Health Delivery Partnership, which is convened by USAID, UNICEF, and the World Health Organization. The need for strong and resilient community-based primary health care has never been more urgent as inequities widen in the face of climate change, food and nutrition insecurity, protracted conflict, economic crisis, and other threats to health and well-being of women, children, and adolescents. Community-based primary health care is a pro-equity approach, meaning demand for and provision of basic and essential promotive, preventative, curative, and rehabilitative health and nutrition services outside of health facilities. In the community and at home, by community health workers, community members, and peers, community-based and community-led groups. For decades, community health workers have been dedicated to reaching children, mothers, and their families with life-saving health, nutrition, and social services, including in some of the most remote and challenging operating environments. The community health workforce has been instrumental in the dramatic expansion in access to essential health services in countries all around the world. Increasingly, community health workers have played a critical role related to global health security, including pandemic preparedness and response. Investment in community health workers not only improves health and nutrition outcomes, but helps create jobs and career pathways, as well as economic development by enabling self-actualization, by strengthening human capital as part of the care of the economy, especially for women and girls. Here with us today is one of these extraordinary women, providing these life-saving services to communities in Kenya. It is my honor to introduce you to Margaret Odera. Margaret, the floor is yours.
Thank you for this opportunity. My name is Margaret Odera. a community health worker from Kenya. Why do I do this work? It is because community health workers save lives. I stand as a living proof to this because it was a community health worker who never gave up on me. When I was first diagnosed with HIV and was in denial of my status and resistant to starting life-saving ARVs, but that community health worker stayed with me, was patient with me, and walked that difficult road with me. Now, I do the same to my community. I perform the same vital role as a community health worker, saving lives. My work holds importance as community health workers impact knowledge to the community members, empowering them to make informed choices. The trust the community has placed in us, community healthcare workers, reduces issues like vaccine hesitancy, home deliveries, family planning concerns, myths and misconception, mobility and mortality rates. Community health workers serves as initial point of contact to detect and respond to outbreaks, subsequently reporting to the hospitals and the Ministry of Health. We are uniquely equipped to reach and re-engage individuals who have lost hope in life, defaulted on treatments, and on denial. Only a community health worker possesses such expertise and has rapport within the community to accomplish this task. In emergency situations, we are called upon to give essential first aid before the patient is taken to the hospital. I am also an advocate and a community health worker organizer and a community health impact coalition that is committed to make professional community health workers a norm worldwide. I have founded the Community Health Workers Champions Network, which brings the community health promoters all over Kenya for the purpose of advocacy. We are 6,000 community health promoters in 43 out of 47 county chapters. We acknowledge that community health workers are not substitutes or replacement for doctors and nurses. Instead, we complement their roles. I urge you to advocate, influence, and invest in policies that will ensure community health workers are salaried, skilled, supervised, and well-equipped with commodities and modern tools. This will enable community health workers to collaborate effectively in strengthening global health security and in achieving universal health coverage. Finally, I am delighted to have my voice representing that of community health workers globally during the launch of this community health delivery partnership today. My appeal is that you will continue to reserve a seat for us at this table so that we can co-design, operationalize, together, track the progress of this partnership from the beginning to the end. I have had a glimpse of what success would look like, thanks to the commendable efforts of the Ministry of Health in Kenya, where the President has elevated our role from mere volunteers to community health promoters. We have been trained and have in our bag packs that are essential life-saving commodities and are now being regularly given stipend. So I urge you to deliver on the promise of leaving no one behind for the stronger global health security. Thank you so much.
Thank you so much, Margaret, for this powerful statement, for reminding us of why we are here. Rest assured that we are all standing shoulder to shoulder with you and community health workers everywhere. It is now my distinct pleasure to introduce you to our convener, Executive Director of UNICEF, Ms. Catherine Russell. Catherine, over to you.
Thank you so much, Joy. I really appreciate it. Thanks for moderating this. Excellencies, colleagues, distinguished guests, it really is my privilege. I can't tell you how long we've been looking forward to this, how excited we are to launch the Community Health Delivery Partnership today, and we're so delighted you can all be here. Margaret, I almost feel like I shouldn't say anything else because I thought your presentation was so perfect and really shows how wonderful community health workers are, how dedicated they are, how smart they are, how much they contribute. And I'm just delighted that you could be here, and I'm really eternally grateful for the work you do. So thank you so much. And I would say to all of us here, whenever we think about community health workers, try to have Margaret in your mind, because she is a prime example of how fantastic they are, and I think she'll lead us in the right direction. So across the globe, we know that community health workers serve as important sources of trusted knowledge in their communities. They provide integrated primary health care and nutrition services, and as Margaret said, they're also advocates, which is incredibly important, advocating for local priorities and needs. In many, many contexts, they are the only healthcare providers for vulnerable populations. Over the last year, I've met many community health workers. They've been fantastic in India, Brazil, the Sahel, the Horn of Africa, and I've seen their incredible work firsthand, and it is just as Margaret says. In countries where these workers are fully integrated in the primary healthcare system, they are at the vanguard of accelerating progress on universal healthcare, which is what we all say we want, right? It's just the question is, how do we get there? Increasing support for these workers will extend their reach in vulnerable communities, and the impact of this work will be incredible. We know, for example, that if community health workers could reach at least 90% of children in need with critical child survival interventions, they would reduce child mortality rates in high-burden countries by a third, which is an extraordinary number. These workers deserve fair pay, appropriate training, safe working conditions, and the tools and resources they need to provide good care. But unfortunately, this is often not the case, especially for women, even though they account for 75% of community health workers globally. In many countries, girls' and women's access to quality education and learning tools remain woefully inadequate. Fair compensation for women healthcare workers is also a serious problem. As Margaret said, there is some progress here, but we need to make sure that these people, mostly women, are compensated. On average, women are paid 24% less than their male counterparts, and women health workers are more likely to experience violence, sexual abuse, exploitation, and harassment at work. This quite simply must change. We have to provide all community health workers with fair pay, with quality education and training, and a safe working environment so that they can provide the care on which millions of vulnerable children and families depend. And by providing this largely women-led workforce with the right support, we can also help to reduce gender inequality, strengthen community health systems, and accelerate progress on universal health care and the Sustainable Development Goals. So I would say, as a general matter, community health workers are a very, very high impact intervention. To support this effort, we have established the Community Health Delivery Partnership, which we're all here to celebrate. The partnership is built on the important principles of national ownership, partner alignment, and equity, and I want to really stop on that point for a moment. These programs work best when they are owned by the community. We are trying to build up community health systems in countries around the world. We know that when countries, when governments, when leaders support this work, it makes all the difference. It makes it much more effective. And so I think that we see ourselves as a critical partner in this effort. And by we, I mean all of the people who are here today, but we are there to work with governments. Critically, the partnership will leverage new investments in women community health workers to ensure they receive the salaries, the support, and the supplies they need. And so we really are trying to mobilize additional resources in this effort. Once the partnership is implemented across priority countries, at least 66 million children and 100 million women will benefit annually, bringing us one step closer to our goal of universal primary health care. UNICEF is 100% committed to this agenda. We will direct additional resources to support the partnership. I ask each of you to join us as we grow our investments in resilient and inclusive community-based primary health care systems to reach all children. Children everywhere, in every place, deserve no less. Thank you all very much for your support.
Thank you so much, Kathy. And again, thank you for co-hosting this with WHO and USAID. My dear friend and our leader, Dr. Tedros Adhanom Ghebreyesus, the head of WHO, a true champion of this issue and a leader, could not join us here today, but he has sent this very important message. Please listen to it.
Minister Jala, Your Excellency, Minister Chiponda, Executive Director Catherine Russell, and Assistant Administrator Atul Gawande, Community Health Worker Margaret Odira, Excellencies, Honorable Ministers, dear colleagues and friends. At the United Nations General Assembly last month, world leaders adopted a political declaration committing to universal health coverage through primary health care. But currently, more than half of the world's population is not fully covered by essential health services. One of WHO's top priorities is supporting countries to close that gap by radically reorienting their health systems towards primary health care. Primary health care can provide 90% of essential health services, providing an effective and efficient path to universal health coverage. It brings care closer to those who need it most and helps break down barriers to access. It's also a first line of defense in detecting and containing outbreaks and other health emergencies. But health services are only as good as the health and care workers who deliver them. They must be supported and protected with decent pay and working conditions. 2/3 of health and care workers are women, so by investing in them, we strengthen health systems and promote equity and development. WHO welcomes the launch of the Community Health Delivery Partnership. My thanks to our friends at UNICEF and USAID for your leadership and partnership as we work together for a healthier, safer, fairer world. I thank you.
Thank you so much, Dr. Tedros, and thank you for walking the talk on this particular issue. And thanks to our WHO colleagues who are with us here in this room. I would now like to welcome the first group of panelists who have very kindly occupied the seats on the podium, on the stage here today. And also welcome the moderator, Dr. Atul Gawande, Assistant Administrator for Global Health at USAID. And just to remind Atul that a very strict timeline, so you'll have to be a very, very, very strict headmaster, taskmaster. And thank you for this, Atul. Over to you.
Dr. Fumafi, thank you so much for moderating and for your leadership. Welcome here, welcome everybody online. We have a challenge in front of us, and that challenge has been posed by countries, by civil society, by Margaret. They are calling for our vertically oriented aid programs for global health to use, support, and strengthen our community health systems rather than the opposite, and follow country-led plans for doing so. We heard from the Monrovia call to action to do so, Minister Jala leading the way. We heard from the Future for Global Health initiatives for this call. We've also heard from WHO calling for a radical reorientation of health systems towards primary care with domestic investment to build support for those community-based health workers and health systems for primary care. And we're hearing from providers of aid that we're seeking to establish that in supporting such efforts, that we demonstrate measurable reductions in preventable deaths and that we show improvement in the essential health service indicators that we are called upon to help support all around the world, whether it's polio, HIV, TB, family planning, maternal child health, global health security. Can we measure that this impact will drive better results? Now, these calls are being heard repeatedly. Some are looking for very specific things: global alignment on payment policies for community health workers, on metrics, on country-level alignment among parties, and on tracking progress or our failure to progress. The opportunity is that there have been, since 2018, a group of numerous health partners who have come together to establish the Community Health Roadmap, which is a partnership that includes UNICEF, USAID, WHO, World Bank, Global Fund, Gates Foundation, the Buffett Foundation, and 16 partner countries, among others, who have come together for supporting and pushing the professionalization of community health workers and inclusion in primary health country plans. And now, this organization of partners, this roadmap effort, which has been around technical guidance and knowledge sharing, has responded to this momentum by seeking today to transform into a community health delivery partnership and making this real, following through on the agenda that all of us are calling for. Our aim is to do our part. So I'm going to turn to these panelists to discuss how we may be able to do so. And I'm going to start with Minister Tedessa of Ethiopia. Ethiopia has been a trailblazer in community-based primary health care and among the world's leading models of community health. And so the question is, looking ahead, what do you see as the single most important need for sustainability of the kind of gains that you've made in being able to build on them?
Thank you very much. And a single investment is always a difficult question, a single solution. But I think I can summarize what made it successful so far is that Ethiopia decided to invest in community health as part of the national health system by investing in it through government, but also aligning with donors and development partners in making training and deploying health extension workers or community health workers and putting them on government payroll. That was the first critical foundation for the strong program of the community health. But it's not only putting that system in place, but the key is the investment to continue in continuously improving and evolving the community health program since its inception, and which is still ongoing. And this started focusing on making sure health goes close to the community through preventive and promotive packages, but continuously increasing the package to respond to the needs of the community based on the community needs as well as the different epidemiologic shifts, so that the package that the community health workers deliver is really meeting the needs of the community. So supporting this, again, by coordinated investments in training, equipping the community health workers, as well as ensuring that they have the needed facilities to provide this care. So we expanded from only rural-based community health program to the urban-based later on, which, based on the context, used also nurses as community health workers, in addition to those trained health extension workers, and again expanding to pastoralist communities. And now we are implementing a new roadmap based on an assessment we did nationally to again respond to the needs of the community, where we see there is increased need to get care closer to the community. And now we're implementing different packages of interventions to be added in the primary healthcare system by community health workers. So the investment with continuous improvement is something that can really achieve the goals that we want to achieve.
It's such a powerful example. I got to visit some of those centers with you just a few weeks ago, and what you see is a place where in Ethiopia, they are meeting the Abuja Declaration. They're at 15% of the government budget going to health, and 3/4 of that budget is focused on primary health care. That result is that even though they have less than $50 per person per year for health care, countries, low-income countries with Ethiopia's income average 63 years or fewer life expectancy. Ethiopia has reached 70 years. And our programs, whether it's HIV, TB, global health security, works through these community health workers in a robust way that I think has demonstrated why that model is so important. Peter, I want to turn to you, Peter Sands, who leads the Global Fund. Strengthening community health workers and community health systems has been a priority for the Global Fund. But you're also passionate about community engagement. We've talked about how we have to engage community around country-led plans. Can you say a little bit more about how we as global partners should be engaging the community in this process?
Is this on? Yes. Yeah, to start with, I think the case for governments to drive plans to scale up, professionalize, as you say, integrate with the broader primary healthcare system, networks of community health workers in the way that Ethiopia has done, are absolutely the right thing to do and one of the most powerful leverage points for improving health in low and middle income countries. And the Global Fund is completely behind that. We've been very involved with Ethiopia for a long time, and looking forward, we're looking at investing over $900 million over the next 3 years in community health workers. But there is, to your question, an issue that I think we have to wrestle with, which is that when we think more broadly than just community health worker networks to community health, this is not something that should be just done to communities. It's about enabling communities to protect themselves. And therefore, it's important that the voice of communities is heard in the design and that they are actively empowered to be part of the delivery of those solutions. And the reality is that works better in some places than in others, and it works better with some communities than others. I note that the subtitle of the title slide is Accelerating Health and Nutrition Outcomes for the World's Most Vulnerable Children. That's a relatively uncontroversial ambition and and obviously an important ambition. But when you're talking about communities like men who have sex with men, or sex workers, or drug users, that's more difficult, and they don't always get a voice in government-led plans. And the systems for engaging and empowering those communities sometimes exist and sometimes don't. And so that when we talk about, and when we have a mixture of government and international agencies on the stage talking about community health, I'm a bit uncomfortable that there's nobody. I mean, Margaret's a fantastic representation, but we ought to have more community voices involved in doing that. So that's just my ask on this, is that we are totally committed to and completely believe in the logic of strengthening community health worker networks, community systems for health, community-led monitoring, which is often about holding governments to account, but we need the communities actively engaged in every step of that process.
It's an important reminder. I think we've seen good models for how civil society and communities can hold accountable to the promises that are made, and that accountability measure, but ways in which you are able to get our hands around such diverse populations to be part of design and the pathway there is a constant effort in progress, and Global Fund has been a standout in finding ways to do that in your governance and so on, so that'll be important for us to learn from.
It's very context specific. There isn't a single recipe that works for every country.
Yes. Minister Jalla, You have led Liberia to champion the work of community health workers with an international PHC forum that led to the Monrovia call to action. Thank you for that. What can partners do to better align alongside your own plans to reach targets for services and for health in ways that achieve mutual goals?
Thank you, Dr. Atu. First of all, we want to thank all of our partners for supporting the Liberia Declaration that have led to us coming to this partnership. The government need to align their health policies and strategies towards one goal. We still have a lot of vertical programs in Liberia, and we hope that we'll be able to align all of those programs towards the community and coming upwards, or the community as the lead. And I'm glad that we were able to bring community health workers to the table this time around to really find out their needs, because in order for us to write policies and strategies, we need them to tell us what are their needs. And I think the voices were widely heard during that meeting, and so we have to continue to put together the strategies and plan in place. We are not looking at only one sector, because health is multi-sectorial. In order for us to meet the nutrition of the people, we need to bring agriculture on board. We need to bring information, gender especially, on board, because gender plays a very important part in the community health work. So we want to make sure that we have multi-sectorial involvement, our strategy in plan, our way of monitoring the strategy, bringing CSOs to the table to make sure that the things we are doing for the community and is led by the community and evaluated by the community. And looking at the whole primary health care focus, we have to make sure that even though we built the community health program, but the rest of the primary health care system have to be in place. Because if we don't have those mechanisms in place, then the community health worker will be frustrated in the end, because there's no system to make sure that, for them to carry the patient forward.
So I'm hearing a theme from all three of you that it's going to be different country by country, those multi-sectoral, bringing sectors together around country-led plans that'll look very different from place to place. And so this community health delivery partnership is going to have to work at the country level. We all have country coordination mechanisms, but those mechanisms are not coordinated with one another. And so we will need to look and support your country leadership to bring those mechanisms together and support that capability is part of what I'm hearing. That's what we will work on. I want to go last to Dr. Petra Khoury, who directs health and care at the at IFRC. And the Red Cross, Red Crescent, you bring together really localized organizations with an incredible footprint, bringing civil society services in the most challenging situations in the world. Many of our biggest gaps are in fragile and humanitarian settings. So how does investing in community health workers come together with the reality of what you face on the ground in many places of the world?
Thank you. The Red Cross Red Crescent, as you mentioned, has a large footprint. We're talking about 197,000 branches, which serves 100,000 communities globally. A base of 16 million volunteers that at the core of their services, we're talking community health, which makes them the largest community health network in the world. And this is a strategic priority for us. Our data shows in 2020, we have 95 Red Cross Red Crescent globally working on community health programs that serviced 54 million people. And the community health workers servicing them were around 234,000. That's what the network has currently. They work in complex settings. in conflict and fragile settings, which makes them the first and only link to health for millions of people. And it makes this a strategic priority for our agenda. What do we need? 3 things. We need partnership like this so that we leverage on our collective strength and collective resources. We need sustainable financing because we train, we provide them with the tools, but we need to retain them. And the third thing is that most of our programming has been vertical in the world, health programming. Let's work together to make it more horizontal. Let's move from a disease-oriented approach to a more comprehensive community health approach, where it's more centered towards the holistic health of the communities. Thank you.
You will be such an important partner in making this work. I want to thank my panel for their very clear and rich and dense responses. We'll turn it back over to Dr. Fumafi. Thank you to all of you.
Thank you so much, Atu. Let's give another hand to the panel. I think a very powerful message is coming out of this. It's country-driven, it's community-driven. It's about people, it's about women, it's about children. Thank you so much, Atul, and thank you, honorable ministers, for leading this charge and for being in the vanguard of this important partnership. Now I am pleased to pass the floor to my good friend and brother, Dr. Gitinji Gitahi. And as we welcome him and his high-level panel, comprising the Honorable Minister of Malawi, Minister Chiponda. Honorable Minister, you are welcome. Ngashi Ngongo, Africa CDC, Mamadi Yila, and Ashan Khan. As we welcome this distinguished panel, you'll notice that both of the panel moderators are wearing purple-flavored shirts. I think this is an indication of what you need to direct a panel effectively. So over to you, Gitinji.
Thank you, Joy. And Atul sent me a memo and said, let's try and wear purple. I didn't have a complete purple, so I tried, So thanks, Atul, for the heads up. Well, I also want to celebrate the gender balance in all the panels again. Thank you very much to the organizers, and I think we must consistently remember that. Now, we don't have a lot of time, so I'll go straight to just some quick points, and then we can discuss this. I work with Amref Health Africa, 65 years of experience within community programming. We know that community health programs work. Community health programs deliver, and that is how we deliver. Through all the money that you give us to implement, we do it through community health workers. And I think that's a fact. Now, the community health workers, as was said very well by Margaret, is that they are not a replacement for skilled workers. They're actually complementary. They are the basis for a primary network for creating health and referral as well when it's needed. So the foundation for healthy population, because they work at the household level where health is made. Remember that health is built at home. Hospitals are garages for repair when things go wrong. I see my friend here who says that all the time. Community health workers provide health services. In our work on malaria with Global Fund, and Peter Sands is here, when we are tracing TB cases and contacts for care, when you're looking at malaria treatment for under 5s, 50% of malaria treatment is actually handled by community health workers at home. We see the same nutrition, which is a subject of conversation here. Antenatal care referrals for antenatal care. Vaccination programs are driven by community health workers, and more recently, mental health care and programming by just adding that to their box. They are also critical for health security. Recently, a quick example in Tanzania, the Marburg outbreak in Tanzania, for those who don't know, was actually reported by a community health worker, 21-year-old young woman who was trained as a community health worker on the border of Tanzania and Uganda during the Ebola time. And they were trained with money from USAID, from US government, CDC, and they were trained to do event-based reporting for any odd cases so that Tanzania could protect itself from Ebola. But then what happened is that there was this incident where a family lost several people, and the community health worker, 21-year-old, at night, reported on her mobile phone and said, there is a strange happening around here, and we think there is something we don't understand. That's all, just the event. That's what made the Ministry of Health go down, send epidemiologists and lab, and then detected Marburg. That's how the world is safe from Marburg today, through community health workers. So thank you very much to community health workers. So services and security. This is what gives a very high return. And we are talking about financing today. We are going to talk about financing. $10 back for every dollar, and that, when we actually engage them, will even be higher. Despite this, only 15% of them are salaried. So we have a huge problem with the financing of community health workers. And even where this 15% are salaried happens, it is fragmented, it is duplicative. We as AMREF work with Global Fund, we work with Gavi, we work with USAID. I can assure you, we pay the community health workers based on the contracts that we have. If it's malaria, we pay for malaria. If it's HIV, we pay for HIV. But there is a movement to bring integration, all the way from the Global Action Plan, which had some successes, and now the future of global health initiatives. And I think that now, seeing the launch of the community health delivery partnership, gives me hope that all the efforts made to integrate the area of least competitiveness for the global health initiatives, using a platform which they all need and therefore there's a common interest, would be a best place to start. So thank you very much for those who are leading the community health development platform. So let me go straight to our panel here because we don't have a lot of time. The first question is going to be to my friend, the Minister of Malawi. Minister Chiponda, Malawi has made progress here. I would like to hear from you what you've learned, especially the area of policy harmonization, because that's a big problem, but also legislation for financing, whether that is legislated, and also the scheme of work. What systems are there to ensure there is sustainable financing and effectiveness for community health programs?
Thank you so much.
3 minutes, I'm told, isn't it? Maximum, yeah? Yeah, but I know you're very brief normally. Yeah.
Thank you so much for the opportunity just to share Malawi's experience. As a country, now what we're advocating for is this strategy of having one plan and one budget envelope and one monitoring and evaluation plan. So that is what we're advocating. In the plan, in our strategy, primary health care is very key, and that also comprises community health care. We also have a strategy which we call accelerated roadmap to community health care. Basically, we're saying what are the 3 or 4 things which we can do, but they'll be a game changers. And what we have noticed is that scaling up, community health care has really worked for us in 2 folds. First is delivery of essential services, especially to women and children and the youth as well. Secondly, it has proven to be an indispensable avenue for emergency responses. As Malawi, we had COVID. After COVID, we have cases of polio, which we have to vaccinate millions of children within a week. We also had the cholera outbreak, the worst cholera outbreak in the last 20 years, which affected a number of people. And of course, we had the West Cyclone Freddy, which affected millions and millions of Malawians. We were able to get to the people because of the community health care worker. And in our case, we have what we call health surveillance assistant, we have nurse assistants, we have also midwife assistants. These are what we consider as community health care worker. So they've proven to be indispensable, especially also in the emergency response. But most importantly, they have also proven that, apart from saving lives, they're also bringing a financial dividend. You might not put a figure, but you can imagine, like you said, you have a nurse for HIV, you have a nurse for TB, but we have only one community health care worker, providing HIV, tuberculosis, immunization, family planning, promotive health as well, on issues of sanitation and hygiene. But most importantly, they're also part of the structure at a local level, local government structures, which we call community health action group. So they interact with the chiefs as well, they interact with the faith groups as well. You are aware that during COVID, we had so much misinformation about the vaccines, this and that, but because they are part of the community group, they interact with the faith groups and the traditional leaders, it was a game changer as well. So those are the lessons which we have learned. They need support. What we have done, we have a 12-month training, which was designed by our College of Medicine, our own doctors. They have designed a 12-month training program for the community health care worker so that we are on the same page. Now, in terms of financing, all of them, they are on government payroll, and we're so grateful to our partners, the Global Fund, USAID, UNICEF, who assist us as well in terms of, supporting community health care worker as well. But also through Global Fund, they're also assisting us in terms of infrastructure. They are staying in the community, most of them in 30-roofed houses, not good enough. So we're saying, no, you build a hospital, you also provide at least 2 staff houses, because we also want to support them, including solarization. We have so many partners who are saying, okay, there's no electricity, we can put a solar there. We are saying, don't just put a solar for your fridge, put a solar which is also going to, accommodate our community health care worker. So we have also launched, that is my final remarks, what we're calling health financing dialogue, whereby public as well as private sector, and all our partners, even private citizens, they have to be part of the conversation. The solutions, they have to be part of the solutions on how do we put in more in our resource envelope for the health sector. I'll stop there.
Thank you very much, Honorable Minister. Very clear. Very, very clear. And you've talked about 2 things, training, some policy framework, and you've also talked about the health financing dialogues that are led. Actually, they have come out of conversations at the Africa Leadership Meeting on health financing at AU level, asking countries to have health financing dialogue. So it's a really good point for Ngashi to pick from. And Ngashi, so what is the role of Africa Union in supporting the countries in implementation of these programs? First, policy harmonization, so that even in terms of service delivery, we know there are countries that where community health workers are only allowed to do 30% of what other countries allow community health workers to do. There is science behind what level of services they can offer, but those policies are not harmonized. So what would be the role of Africa CDC in convening in this harmonization, in supporting the countries to actually make sure that there is better political commitment to these programs? Over to you, Ngashi.
Yeah, thank you very much for the question, and also I'd like first to start by thanking the organizers for inviting Africa CDC to be part of the discussion. Let me start by saying that the work of Africa CDC focuses in 2 areas. One is building resilient primary healthcare systems for the achievement of universal health coverage. And then second is improving health security through pandemic prevention, preparedness, and response. If you look at those 2 important areas of our work, you notice that community health and community health workers are central to both. And you remember that since 2017, the head of state endorsed the 2 million community healthcare initiative. That to show the commitment that is already on the continent, really to make these community health workers an important part of the health system. And in addition to that, last year there was a high-level meeting that was convened by the Commission and Africa CDC, which recommended the establishment of a continental community health workers coordination mechanism to ensure that the work that everyone is doing is really aligned with national priorities and also is coordinated. In addition to that, the recommendation also added that we also needed to identify champions including a sitting head of state, to be able to influence that policy harmonization at the head of state where they can speak among themselves in addition to the traditional champions that we've used in the past. Now, Africa CDC, to carry out those commitments and those recommendations, we have been working in a number of areas. The first is this continental coordination mechanism that has been established. I think the importance of that is just to ensure that what was already raised here in the beginning, that the partner investment are fully aligned with the national needs. I think it is critical because quite often we see the top-down kind of approach where the support comes with defined priorities that sometimes do not fit the context that they are going to apply. And then the second thing is for this coordination mechanism we've established also what we call the joint country support system, where from the coordination mechanism all the partners come together and go to a country and help the country put in place that one plan, one budget, and one M&E within the spirit of one team. We've already done that in Sudan. We are doing that in Sierra Leone, and we really want to be the model that we can really roll out on the continent, that no one goes alone to influence the agenda of community health, but we go as a team in support of the Ministry of Health to support what should be the plan of that country. Now, the third area that we are also working on, taking advantage of the unique position of Africa CDC as an institution that is established by the member state, is this high-level monitoring, accountability, and advocacy. I think we were just discussing last week with our colleagues from the Commission that we need to take the scorecard. I think Joy is here. I think that's part of Joy's leadership in terms of AMA, the leadership that they started with AMA. We'd like to build on that, to have one scorecard which could be presented every year in February to the head of state as a way of now feeding back to them to show exactly how the progress is moving. But we also add an accountability because every report will also have an analysis that points to the successes, to the failures, but also some of the recommendation in terms of what needs to be done to carry that forward. That's why, as part of the scorecard, we'll monitor things like the institutionalization of community health, the financing of community health, the number of community health workers that are being recruited, so we can feed back to that. Now, to finish, I just want to say that we fully support the community health delivery platform. We are privileged to have been part of it from the beginning. We see a game changer in the sense that this is a kind of bottom-up approach that allows this continental coordination mechanism we've established to feed back into the global and to help us address the two main issues that we've struggled with partners. One is the fragmentation of interventions, always disease-focused. We want to move now toward the package of intervention and the financing that is translated toward a one budget with pooling of resources. Thank you.
Thank you. Full support of Africa CDC. So thank you, Dr. Ngashi. Please, let's clap for him. And Dr. Mamadi, 25 million lives, 20 years, what have you learned on the effectiveness of community health programs in delivery of this success of PEPFAR and other programs within the Global Health Department of the US government?
Thank you very much for that question, and it's a pleasure to be here. To be honest, this partnership is actually one of the most significant things I think that we can do. I'm really excited by, and I want to congratulate our colleagues who have been responsible for bringing us together, because this is doable. Actually, it is very doable, and it is a place where we don't have to compete with one another because it makes so much sense. So I'm referring to this as the coalition of the willing, and as PEPFAR, those 25 million lives, those results were on the backs of community health workers. We used community health workers. They were not integrated into the broader health workforce. We made them volunteer. They were often unpaid, unsupervised, unequipped, undertrained, and it's a different world today. And so I think what I want to just say is let's deliver a costed and prioritized national community health plans. Let's include all essential interventions. Let's back the country plan, and PEPFAR commits to being part of the solution.
Excellent. Thank you very much. Everyone is all systems go. So let's end with Afshan. From the SUN movement, nutrition is critical to delivery of healthy communities, women, children, adolescents. So what is it that community health workers you've seen can add to the agenda of a well-nourished and healthy population? We have only 1.5 minutes remaining, I see. But I know you're very crisp in your communications.
So, first of all, thank you for the opportunity to be here. And I think when I hear about the people-focused community workers have been trained to screen children in communities where they live using simple tools such as color-coded tape. So in 2022, 182 million children were reached with services to detect child wasting, an 18% increase over 2021. And much of this is due to the success of community workers. So like PEPFAR, we've seen that these successes have been built as a result of the commitment of these community health workers. When we look also at the updated guidelines coming out from WHO, child wasting management will improve because it recommends that community health workers can provide life-saving treatments with ready-to-use therapeutic food at the community level, in addition to screening and referrals. So we're really seeing a game changer. I think the evidence shows that we can shift from treatment from health facilities to the community that will have the potential to improve treatment coverage. And lastly, I would say that that training, that payment, that ability to bring people together, that is a people and child-focused service, will be essential to not just tackling the health needs, but the nutrition needs of children, women, and families as well. And that integrated people-centered approach is the way the SUN movement at country level has focused interventions around one plan, one budget, and one investment strategy.
Excellent. Thank you very much. One plan, one budget. Back to you, Joy.
Thank you so much, Getahi, and thank you, panelists. Let's give our panelists another hand. So it's all about partnership, and we all believe in the power of community health. We know that community health remains critically underfunded. We must support government in creating the fiscal space for investment and commit to aligning donor resources to ensure this essential building block for a resilient health system is adequately financed. So it is my privilege to invite my brother and friend, Pablo Uribe, Juan Pablo Uribe, the Global Director for Health, Nutrition and Population at the World Bank, and the Director of the Global Financial Facility for Women, Children and Adolescents, to share his thoughts and to close the day for us.
Thanks so much. So I know I have 30 seconds. Huge thanks to Joy, huge appreciation and recognition to USAID, to UNICEF, and to WHO, and to the colleagues who have been leading this in these organizations. Admiration. Much have been said, and very clearly and very strongly, Margaret, thanks, about the value of community health. I hope we don't forget it when we go out. I just want to highlight two messages which are not new, but for me are the ones that I will travel with in my work at the bank and in the GFF. The first one is that this launch is about something very particular in community health, and it's about transitioning to action, to the delivery of community health. It may be very simple what I'm saying, but it's the most complex area of the work we do. It's again not defending the concept, it's making it happen at the field. The second message I want to highlight, it's about a partnership that takes place not in this room and not globally, but around country leadership, around countries themselves and in the communities of those countries. It's there where health and healthcare take face and become real, and it's there where this delivery partnership has to succeed. And in that sense, I just want to reiterate all our commitment as the World Bank and the Global Financing Facility of working with countries and country leaders and with these great partners in making this happen in the communities. Thanks so much.